represented here today along with the faculty and staff and students at Johns Hopkins School of Medicine, School of Nursing, and the Bloomberg School of Public Health. It's really my pleasure to introduce today's speaker because he's not only a colleague, but I also consider him a friend. I first met Tom Bauer in the garage at the McElderry garage building when he was moving into his office. And I knew that because he was carrying some lovely prints, which is something you don't usually see in the garage on campus. But I was so thrilled because, first of all, it was recognition of the really essential need for someone in the position that Tom currently has, which is the Senior Director of Patient and Family Education for Johns Hopkins Health System. And secondly, because we were able to recruit someone of Tom's stature and experience to be in this position. And then third, and equally important, is he's a fellow Midwesterner. We're both from one of those flyover states that people on the East Coast generally are not aware of. So it's an extreme pleasure to present to you today Tom Bauer, who is a colleague, a friend, and I do want to mention he's currently leading a very important effort. We're ramping up a campaign for smoking cessation, a tobacco-free campus, and he is leading the charge as far as developing patient education materials, care plans, as well as order sets for that. So we've worked together on a number of other projects, and he's just a really tremendous colleague. He didn't want me to go into his bio, but I can tell you it's extensive with lots of prestigious awards and acknowledgments for the work that he has done. I think that will be very apparent to you, though, once you hear him. So with no further ado, Tom.
Thank you. Good afternoon. I'm glad to be here. I'm going to wander around. Today's presentation, this is from a colleague friend of mine, Michael Pasha-Orloff and Michael Wolf, and they kind of take a look at the pathways between health literacy and outcomes. And we're going to focus on this side of the equation. And so I just wanted to give you a feel for we're talking about the patient side, the communication side, the health literacy side of that equation. And when I think about health literacy, it's the capacity to obtain, understand, and act on health information. And so when you think about, there's various definitions, actually the current definition from the government is under review. But it's really obtaining it, understanding it, and using it. Can't hear me? What's that?
Sound quality?
Okay, you have trouble hearing me? Is this better? All right, so I'll stay here then. Now, when you think about the impact of this, it's 9 out of 10 Americans today do not receive health information in the way they can use or understand. And that comes from the Department of Health and Human Services and was part of the work that was done for the Accountable Care Act. And when you think about that, 9 out of 10, that's a very, very large number. When I'm in a room with health professionals, generally what I ask them is, how many of you get a phone call from a loved one and you kind of go, you shake your head just a little bit, and you realize that they didn't understand or misunderstood the conversation. So, and almost everybody raises their hand because it happens all the time, and it happens to all of our loved ones, including ourselves at times. And so when you think about it, health information is extremely complex. I've been in healthcare now for over 40 years. And the amount of knowledge is increased so significantly. The regulations, the technology, what we now know, it outpaces us in our ability to keep up with it, let alone our patients who are not trained professionals. And so the ability of those two colliding together really are part of the definition of health literacy. So then why is it so hard to understand? And one of the things that happens is that it's anxiety, and I'll talk more about that in a little bit, but being in a healthcare encounter is anxiety provoking. And then I think a lot about when I was in trigonometry class. And I have to tell you, that was the class I least liked. That calculus were the two that I really didn't care much for. And I would tell you that my teacher probably didn't know I existed because I never asked a question. And the reason I never asked a question is I never knew enough to ask the question. And so sometimes our patients find themselves in that very same position, that when you're asked, do you have any questions, there are none because they really just never understood. And then low health literacy, we talked about the fact that 9 out of 10 Americans today have low health literacy. Time is a huge factor, be it for the healthcare professional, but also for the patient. I still think about, I was at my doctor's office a number of years ago. I was his last appointment of the day. He was running late, and I had to be somewhere. So time was a pressure for him. It was also a pressure for me because I needed to be somewhere. And so that compromised the quality of the visit. Medical jargon. Anybody have a guess at how many words we learn when we enter the profession of healthcare? Just throw a number out.
1,000.
Keep going.
5,000.
It's 24,000. 24,000. So when you think about that, if I know 24,000 words in another language, I could get by on a day-to-day basis. If I knew 24,000 words in Spanish, for example, I wouldn't be completely fluent, but I could definitely get by. And so when you think about healthcare and the words we use, that is an entire new language. And I still remember as a very young X-ray tech years ago, feeling really wonderful having been in a conversation with a whole bunch of veterans and recognizing the fact that I knew what they were talking about. And so when you think about it, it's a foreign language. Not listening, all I would ask you is to reflect on your conversations with your family and friends. And you know during that conversation you thought you said something and they heard something different. Listening is one of the least developed skills in humans. When you think about it from the oncology side of things, there's also some other complicating factors. Is that when you think about the web, people go to the web frequently for information and talk to each other in support groups. There's a growing amount of inaccurate information. There's some reports that show that about 50% of the medical information on the web is inaccurate. It's either out of date, biased, or other different factors. Social media has been a major factor in the inaccuracy as well when you think about the anti-vaccination groups, things of that nature. And then also just declining trust in authorities and social institutions. And then difficulty of just spreading information. So there's a fair number of things on the slide, but oncology definitely has been impacted by health literacy challenges. So I'm going to start with a little bit of a story. So I was preparing to talk to a group of about 500 nurses one day. It was 8 o'clock in the morning, and for those of you who know me, I am not really good at 8 o'clock in the morning. It is not my best time. Catch me more about 2 and I'm doing really well. But 8 o'clock, I need to get some energy going, which meant I was an hour from the presentation, which meant I got up about 5:30 to get there for my presentation. So in my car, and I'm not a coffee drinker, and so in my car, what I did and I do is I listen to some very lively music to kind of pump me up to get ready for the audience, to get me ready for the show, as it were. And on that particular day, I was listening to Bruce Springsteen. And so there's a song called I'm on Fire. And some of you, it's probably older song than maybe some of you are, but in that there is a lyric that says, sounded like a freight train running through the middle of my head. And so as I was on stage in front of this large gathering of nurses when we were introducing health literacy, I said, you know, when you hear the words, you have cancer, it must sound like that Bruce Springsteen song, with a freight train running through the middle of my head. And just as I said that, a nurse stood up, raised her hand, and said, Tom, I am a breast cancer survivor. And when I heard those words, that is exactly how it sounded. And that was one of those moments as a speaker, my hair just stood up everywhere. Because when you think about that story and what her impact was, that's our patients, be it cancer, be it any other sets of bad news. At that moment when you hear those things, it's a short wire. And you can no longer hear anything after that. And there's that time to kind of collect yourself. So this helps explain this slide. There's studies done at University of Minnesota and others that have followed that say that 40 to 80% of medical information in a healthcare encounter is forgotten immediately. And of up to half of that is then remembered incorrectly. So those are staggering numbers. And then the second part of the study said the more information you share, the lower the percentage of recollection. And so we're going to talk about some techniques in a little bit about how do you resolve those deficiencies. When I think about it from an oncology point of view, the numbers really replicate themselves. And you can see them across here. This one here I thought was interesting. More than 60% of patients overestimated their chances of cure by 20% or more from their physicians. One-third of patients with metastatic cancer from different primary diagnoses actually thought they were localized. And so when you think about that freight train running through the middle of their head, these become very understandable. Here's the other part that I find absolutely fascinating. And I want you to think about your conversations last weekend with your family. There are times when you've had conversations and you said, turn right, and they heard turn left. And then there's the argument that ensues. That happens in the healthcare setting, and what the studies show that our healthcare professionals think, there's a couple different studies, but somewhere around 80% of the time that we're effectively communicating. When we talk to our patients, they're not agreeing. Various studies show somewhere around 50% of the time they're feeling that they're effectively communicated with. So there's a gap in the perception. And one of the things that I found in my work with health literacy is when we use some of the best tools in health literacy, one of the outcomes from a healthcare professional's perspective is the word humbling. And that's the most common word I hear, because what happens is that when they use teachback to have people repeat back what they learned, they find that they hadn't been as effective as the communicators they thought they were. So let's talk about the impact. This is really my favorite statement if you look at all the impacts. Nothing impacts a person's well-being more than literacy. If I don't know what I need to do to stay healthy or to get healthy, how can I? And so that really boils down into my mind, the bottom line. I look at it from the Quadruple AIM perspective. IHI has a kind of way to measure change, and we look at the fact of the quality of care, the cost of care, satisfaction for the patient and the healthcare professional. And health literacy crosses over all four of those domains, and I'll talk about that a little bit. When the government did the studies for the Accountable Care Act, so some of you might know that as Obamacare, so when that came along, there was something called the National Action Plan to address low health literacy. And inside of that, there was a study that said, if we could successfully address low health literacy, we could reduce the cost of care by 17%. So what that means to you and I is the premiums we pay and the co-pays and the amount of out-of-pockets, all those things would reduce by 17% if we could address this opportunity. So for the government, it's $58 billion, and that was about, 8-9 years ago now. And so it's also then obviously a predictor of cancer risk, participation, and so forth. So let's talk, so we talked about the problem, so let's talk about some of the solutions. And when I think about this, I actually borrowed this slide from my friends at Vanderbilt. I was at a conference that they presented this slide. I refocused it a little bit. But start with what behavior you're most likely to want to change. What piece of knowledge do you want to impact or change? Then think about the skills and resources that you need, and then focus on that key message. And you'll see later on what I'm talking about here is if you think about something like diabetes, that is a massive amount of information a person needs to learn. So if we can focus on one single piece, one key element, building block, and build on that building block using this strategy, and then build another block, then we can help that person better understand. I'll talk about that a little bit more in a couple seconds. I like this statement. I borrowed this from the National Academy of Science, had a roundtable on 2019 on oncology and health literacy. And so the slide comes from there. And what they said is the clinician, not the patient, is responsible for effective communication. We own that. Universal precaution principle. And what they mean by that is since 9 out of 10 Americans do not receive health information in a way they can use or understand, what that means then is that we treat it as a universal precaution and make the assumption that everyone has an opportunity to better understand their health care. And as a good friend of mine explained one time, he was the chief medical officer of the last organization I worked for, and he was talking to a group of his medical staff, and he said, you know, if I talk shop to a nuclear physicist, they will not understand. And if that nuclear physicist talks shop to me, I will not understand. It doesn't mean that either one of are dumb. It just means that we didn't clearly communicate. And so if you really boil it down, that's really what it boils down to. And literacy and numeracy are both important practices here, which there are opportunities. I'll talk more about that. The next part is that we all learn differently. And I know there's a number of students in the room in the audience. So what I want you to think about is your classmates. When I was studying for my master's degree, I was sitting with two other people who went through the program with me. We just took the same courses and went through the program together. And my friend to the right would write massive amounts of notes. And if you sneezed or said something to him or poked him, you got the most interesting look, I'll just say it that way. My friend to the left had their book was highlighted, there were notes in the margin, all this other kind of stuff. And there was me in the middle. My book, you wanted my book at the end of the semester because I never cracked it open, or very rarely, I'd scanned it. But I locked in on the professor and listened to all their words and watched all the visual side of this. All three of us got the same exact grades. We all learned differently. And so when you think about our patients, they all learn differently. So I have examples of written and visual and tactile and oral up on the screen there. So let's talk about oral. One of the programs that I like a lot is Ask Me 3 because of its simplicity, and I've had the opportunity to train over 30,000 people in its use. And so what Ask Me 3 does is it focuses on the patient learning what is my main problem, what do I need to do, and why do I need to do it. Ask Me 3 was originally developed as a tool for the 3 questions a patient should ask in an encounter. And what we did in my early work was to not only train patients to use those 3 questions, but in addition to that, to ask healthcare professionals to use this as the framework of their conversations. And what we learned is that in our profession, we are really good at saying what the main problem is. We're very good at sharing what you need to do. The opportunity lies in why. I just want to share with you that this is actually supported by the National Patient Safety Foundation and IHI as a best practice. So the opportunity is why. Why is the activator? If you remember, if you have kids or remember when you're a kid, there is that phase in life where you go, why, that inquisition to learn. That's the activator. When I know why I need to do it, I'm much more likely to do it. And when you look at generations, the younger generations, the ones past the baby boomers that have been born since the baby boomers, actually it is a part of their life experience. For the baby boomers, what had happened, we used to ask why a lot, and we didn't always get an answer or response that we appreciated. And because we didn't, what happened is as we raised our children, we always told them why. Eat your vegetables because. And so generationally, there's some research showing that fact. And so the why is the motivator to adherence, and the why into the understanding and the conversations that might follow. The funny thing about this is I had done some research on it, and I found in heart failure patients at a large hospital in Charlotte that the why was covered about 24% of the time. When I came to Johns Hopkins, I talked to a researcher in our heart failure unit, and we were talking about the same thing, and his information was the same. It was 24%, which I thought was interesting. And so when you think about the why, it's really the driver of adherence. And just a short story about that, there was a time where I was placed on a medication that I would have to take every month. And I went to get it filled. I knew exactly why I needed to get it filled, and it turned out it was $80 some to get it filled, and I'd be taking it monthly. So that's now coming close to $1,000 a year out of my pocket. Because I needed to take it, I bought it, and because I could afford it, I bought it. But I got to thinking about how many people would not be able to afford that medication. The next month, I went back for my refill, and it came out as a $5 generic. And then I realized at that moment that the price barrier had just fallen for folks. But how many people would know that? So at the same time, there was a study that came out that said about 4 times as many people, this is during the housing bust, that about 4 times as many people were not getting their prescriptions filled as they had in the past. And part of that was price. They were just leaving it at the countertop. Well, if I couldn't afford that $80 at that time, but I knew why, I would be more likely to say, listen, I understand why I need to take this medication, but I can't afford $80. Is there something else we can do? You would know it as a therapeutic equivalent. And in this case, 1 month later, that same med was available twice a day as a generic. And so that's why the why part becomes so important, because if I don't understand the why, I'm more likely to walk away from that pharmacy or not to go to get the test or whatever it might be. When I think about if I leave you with anything today, if I leave you with any tool, this is the tool. What we know about TeachBack, it is the most effective way of measuring the fact that the patient understood. And when you think about TeachBack, it's kind of a fascinating thing, because when it's done well, not only do you increase the transfer of knowledge, you improve your clinical outcomes, and you improve your patient satisfaction. And so typically the way I teach TeachBack is this. Sam, I want to make sure that I did a really good job of sharing this information with you. Can you tell me what you need to do when you get home? And then the hard part comes, being quiet. Letting Sam share what Sam heard. Once they share that with you, remember the numbers I share with you, the transfer of knowledge, you're going to find opportunity most of the time. Then the ability to reteach that to Sam in a different way, and then check for the transfer of knowledge. In the work I did in the heart failure clinic, we were able to move the transfer of knowledge from 38.5% to 85%. We were able to drive patient satisfaction levels higher, and we were able to reduce the readmission rate. We replicated those numbers on a stroke unit as well. So TeachBack and Ask Me 3 together produce those numbers, and were very, very powerful tools. So this is the TeachBack cycle. Complex conversations. So I talked about diabetes a little earlier. When you think about diabetes, one person said diabetes reminded them of that they almost had to become their own primary care provider. That's a lot to think about. And so and I've been in a situation in the past where I worked with a program that what they did is when their newly diagnosed patients with diabetes were admitted, what they did is they had to go to an 1.5-hour program before they were discharged. And they talked to me about what I thought about that. And what I shared with them is that you're overwhelming the patient, and the retention's probably not what you're going to be looking for. Because when I think about myself in trigonometry class, what happened is some classes, I could sit there and I could follow the teacher all the way through. Those were the good days, and they were few. Most days, somewhere 10% of the way to the class, halfway through the class, the teacher had passed my level of what my brain could handle for that day. And then all of a sudden I started thinking about, because I was in high school and college, about what I was going to do on the weekend. My brain had turned off. My teacher had turned into Charlie Brown's teacher, and it was blah, 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 because I couldn't handle it anymore. Our patients are no different than that. And so the idea is when you build a house, you take a brick, you put the brick down, you put some mortar around it, you put the next brick, and you keep going that way. And so the idea of chunk and check is to take one foundational element of knowledge, teach that, validate the transfer of that knowledge, and then put down the next brick. realizing that sometimes that's going to be multiple sessions, more than likely for big things, and that each patient's going to be a little bit different in handling it. But the idea to slowly add information. And what I would tell you is for the students in the room, and all of us have been students at one point, that would be synonymous to taking your least favorite class. And if I said to you, what I'm going to do is give you a crash course on your least favorite class, and it's going to be 8 hours a day for 5 days, that would be a very long week for you. But if I took it over a semester and made it an hour and a half a day, twice a week, that's much more digestible. Allows you time to learn it, digest it, and then take the next one. Does that make sense to everybody? Okay. Use plain language. This is a fascinating one to me because when you think about the 24,000 new words that we learn, I feel masterful when I know them, but as a patient, what happens is often, even though I'm in the field, I hear words that I have never heard before and new things. Our patients are the very same way. But then add a complication to it. When I first came to Johns Hopkins, I was sitting and talking to a group of folks, and they were talking about the Jayhawk exit. Well, what had happened is I had parked in one of the garages that on the floor they had pictures of the Orioles. And so I'm new to Baltimore. I know it's the Baltimore Orioles. And so I see these pictures of the Orioles. So I'm thinking, okay, I know of other hospitals that the different floors have different, like at Rush, they have different musicians and music playing. So I thought that was the Oriole level, and then you might have a Cardinal level or something like that. So as they were talking about the Jayhawks, I'm thinking about the Kansas Jayhawks. I had no idea it was a Johns Hopkins outpatient center. And so we also throw into not only the words we use, everything has to have an acronym. And so that also then leads to a lot of confusion. I'm seeing smiles in the room because you've dealt with the acronyms too. And so those all become confusing. And if you add that up to a person who's scared, anxious, nervous, it becomes difficult. And one of the things that happened to me, just to put that all into perspective, I hate to share all these things about me, but I've had so many, like all of us, we have experiences, so I think it's important to share them. I was having a procedure done one day, working in this in the building for 2 years. My wife comes and sees me 2-3 times a year. And I come walking in the door, I know where I need to go. But I was so nervous, my wife grabbed my hand and said, let me take you to where you need to go. In my building, in my work, and that's my job. And she had to take me there, and she's only been here like 4 other times. That's how nervous you can become. And so in that state, how can you remember some of these things? And then add language and others. So what did you say? These are words that we think and use every single day that people don't understand. 35% of people understood the word orally. 18% understood the word malignant. 13% understood the word terminal. Less than 50% of men with prostate cancer understood the words below. And it continues. And so these are all words that become difficult. There's a couple lists that show the more common words that are difficult to understand. But some friends of mine, actually a couple of those are run by friends of mine. There actually is a thesaurus. There are several thesauruses that are available on the web where you can take the medical term and you can put them inside there and it'll give you a more common or lay term, the words we used before we came to work in healthcare. And a couple of them also have inside of it the medical billing terminology, things like out-of-pocket deductibles and stuff like that, copays. Those are included in there to help people understand those because that's also a complicating factor in healthcare. Numeracy is a challenge. When you start thinking about, I shared with you trigonometry is one of my hardest courses. For most people, math is a difficult thing. And a lot of times when you get a prescription and it's drop form, it might be in the milliliters. A lot of times we talk about cc's, we talk about a lot of metric measures, and most of our patients operate in English units. And so those become factors. And then you have the transfers over when you look at weight, so much per weight, those types of things. When you look at insulin and doses that are varied, sliding scale doses, those type of things all become very difficult. And so when you start looking at those types of things, the use of teach back or return demonstration, where having a patient be able to share. So if you're, for your son, what would you give them when you show them the bottle or show them how that is? Those become very important considerations because people sometimes get very confused. I'm aware of, in my past work, of at least a couple of people that were airlifted because they misunderstood their insulin dosages. So numeracy becomes an issue. I kind of like the line there. So let's talk about written education. Does anybody know what the average American what the reading level is for the average American? I hear 7th, and what else do I hear? 5th, 6th. Depending on who you read, it's somewhere between 5th and 7th is where you see it. It's kind of, it used to be papers were written at a much higher level. They've moved them down. We try to write most health information somewhere between a 4th and a 9th grade level, because if you have to use the word staphylococcus, you're not going to get to a 4th, or rehabilitation, some of those kind of things. But we try to use clearer information. And so at Johns Hopkins, we have a repository that contains our health information in it. What we've done is we've scanned that material to assure that it's consistent with the best practices in health literacy. And some of those things really boil down to using language that people clearly understand. So when you think about medical jargon, trying to eliminate it, and when we need to use it, what we do is we take and put a word behind it that is more commonly understood. We try to use short sentences, avoid the use of commas and semicolons and things of that nature, because that leads to confusion. And then there's another thing, and I'll kind of take you back for a moment. When you were in school, or if you're now in school, and you're reading a book, and the teacher says, listen, I need you to read chapter 4 before our next class. What's the first thing that you do?
See how long chapter 4 is?
How do you do that?
Look in the book.
Yep. Does anything make it feel longer or shorter? I'll help you out. So what happens most of the time is you flip through those pages. And when you flip through those pages, if there's a lot of white space and pictures, you smile. If there's full of text and it's dense text, you go, oh, I'm in for a long night. And our patients are no different. When you have health information, one of the important pieces to that is to have a nice layout so that it's got lots of use of white space, because that's really, it's considered intimidating when you have a dense document. And so the use of spacing is a critical component of that. There's a tool called the PMAT that I use frequently to help me look at those kind of things. There are tools that measure the grading level. If you're ever interested, grade level, if you're ever interested in that, I'd be glad to share them with you. But what we do is we have material that's clear, it's concise, the layouts are good, have imagery that supports the text. And so when you look at the wording, because it's not, the key to imagery is not to have it so that it looks like somebody's happy and smiley, but that the information, the image supports the information that's being shared. And so a lot of times we have diagrams about how to do certain things, that type of thing. Not to say that it's not important to have smiley people from time to time, because that connotes warmth as well. The other thing is when you hand out that information, when you go through it, some people tend to just hand out the information. The more important thing is to hand it out, show it to the person, go through the key points as you're talking with them, and highlight the key points, because a lot of documents are very dense and certain parts are more important to another person. So if you can highlight it, it helps that patient focus on what's right, or what's important to them. Video education. When you think about Americans today, we tend to be very visual learners. And what I would refer you to is YouTube. And one of the things that happened for me is I was sitting at home thinking about a wonderful weekend I was going to have, because I didn't have any projects that weekend. We were just going to be able to play a little bit. And my wife opened the back door, and it was sticking, and sticking toughly. That meant I would have to deal with that. Now, I can recall times when we fixed that door before with my dad when I was a kid, and it wasn't pleasant, because we had to take the door off and do the shaving of it and all these other things, a lot of work and a lot of time. And so when I saw that, I thought, oh my goodness, here goes the weekend. And I thought, you know what I'm going to do? I'm going to go to YouTube and see if anybody's come up with a way to fix the door that I don't have to do all these things. So I go to YouTube, I look at the video, and there's a guy who says the first thing that you do is sometimes they put short screws in the jamb, the hinges. And if the screws are too short, they become loose, and the door leads forward and it sticks. And if that's the case, you just need to put 3-inch wood screws in to secure the door. So I went out, pulled my drill out, got it, little short screw. Put the 3-inch screws in, next thing you know, the door snugs up. I'm now superhero, and the weekend is good. Our patients are very used to doing those kind of things. Most of us in this room have probably looked at YouTube to fix something or to learn something. The average person in the X and Y generation averages around 3 hours a day in YouTube, according to some of the research I've been looking at. So visual video becomes an important part of our tools and our tool belt to help bridge that gap of health literacy. And so at Hopkins, we do have a very robust library of information that is used to support us in a visual way. We can prescribe them through our EMR. We can see who watched it and who didn't, and we've measured the success. What we have found and learned is that around 80% of the time something good happens when they watch a video. We find that patients feel more prepared, which leads to better conversations. We found the transfer of knowledge improved. Patients feel more prepared for their procedure. They rate the organizations and their provider with higher levels of satisfaction. And they understand their benefits, risk, and options more appropriately. And that happens to do with a set of videos that we have. And so a very, very powerful tool for us. Tactile education. One of the things, and I don't have a picture of it here, but one of the things that happened is one day I was talking to what's called a fragility navigator. And what that person does is they teach about osteoporosis. And being a former X-ray tech, I've seen osteoporosis on radiographs for years. And I worked in an orthopedic office for years, and so I've seen patients with it. But she gave me a complete and total new appreciation for what osteoporosis was. And it was by simply asking this question. While we were sitting and talking in her office, she had a shelving unit behind her. And oddly enough, she had 2 femurs on her shelving unit. And I said, why do you have femurs on your shelving unit? And so she reached back, grabbed one of them, gave it to me. The femur is the big bone over here, for those who don't know, it's the big thigh bone. She gave it to me, and I grabbed it, and my hands went, psh, that's a heavy bone. And she said, okay, now. So I put it down. She grabbed the other one, gave it to me, and it was nothing. There was no weight to it. And she said, the first one was a normal femur. The second one was a person with severe osteoporosis. And at that moment, I completely and totally understood osteoporosis. The ability to see, touch, and feel is a powerful tool. So when you think about the way people learn, to be able to hear it, see it, feel it, touch it, those type of things, we all learn differently, and we're all a mix of it. Sometimes it's as simple as drawing a little diagram. Sometimes it's showing a radiograph, some of those things. And then one of the other things that happens is then we have frequently patients who speak a language other than English. And the importance here that I leave with you on this one is that there are many methods to use an interpreter, but please use an interpreter. Because when you think about the 24,000 new words you learn in medical terminology, and you think about English, and you think about another language, that interpreter is actually managing 3 different languages and getting it to that patient. That is not easy to do. And interpretation is not word for word. It is meaning for meaning. It's culturally sensitive. And so that's a very gifted individual there who's helping with this conversation. And if you use family, they may not know the right medical terminology and the right way to explain it. And so you're risking the transfer of knowledge. In some cultures, they don't always share bad news. And so the person doesn't hear the thing. And the thing that bothers me the most is, can you imagine telling a loved one that they have a serious condition? That's just not fair. And then for yourself as a professional, making sure that you are communicating as effectively as you can by using someone qualified to do that for you. And that can be done in person, it can be done on the phone, and it can be done, if you think about it from this way, we can Skype, FaceTime, whatever you want to call it, but screen share an interpreter into the room. And that way you always have access to that person. One of the things I learned along the way is sometimes patients, we always think that in-person is probably the way people most prefer. There are some patients who do not want an in-person interpreter because what they worry about, and I've had this happen a couple of times, I'm not saying everybody, but there's a segment, that they feel funny having someone, because sometimes communities are small, so the person sitting next to them at a social event or the club or their church, they don't want them in the room as the interpreter. It's just a privacy thing. So having someone from the outside involved, just to keep that in mind. We do have written materials that are available in languages other than English. We happen to have 18 languages at Johns Hopkins, and then we also offer videos in languages other than English. It's not as robust, but it's growing. When I think about things, the idea is to inform the patient. That's the basis of engaging and activating, because when I know what my situation is, and I know what my options are, I'm more likely to get engaged and activated. And so I don't have time to go into details on all of this today, but I want you to be aware there's the growing science of motivational interviewing. And with motivational interviewing, it's reaching at what is important to that person. And so a little bit of a side story. I'm going to go away from healthcare for just a half a second. I was driving down the road in North Carolina, and there was a large discussion on one of the shows, kind of the laugh kind of morning shows to get you kind of thinking and laughing for the start of the day. And they were discussing this lady who had been married for 40-some years, and that they had just published her will. She had passed away. And in that will, despite being married for 40-some years, she left nothing to her husband, nothing. She had left her entire inheritance to the well-being and care of her cat. And they were talking about that. And I got thinking about, being the healthcare person that I am, is can you imagine if they were in the hospital and they kept on talking to this lady, listen, we need to get you better so you can go home and be with your husband. No. The key thing that motivated her was to be home and make sure someone's taking care of the cat. Someone to change the litter box to make sure that cat was fed well and so forth. So important to the fact that she actually included that in her will, the brand of kitty litter, the food, how often, all those things. So the importance of knowing what motivates that person, what is their driving force, and getting to know that person as an individual and touching them. That's one of the keys once we do the information, but what motivates change? And so we have some wonderful professionals at Hopkins that work in this particular area especially. Shared decision making. I often tell people shared decision making is much like our decisions to drive home. There are probably a dozen methods, roads that I could take to get me home. There are days I choose one route because I want to stop at a certain store to pick up a grocery, or I want to get gas, or there's certain days I leave at 5 o'clock and hence the roads are all congested and I want to take a different route. If it's raining or snowing, I take a different route. Sometimes GPS just tells me a faster way to go home is this way. But all those roads get me home. For our patients, in shared decision making, making them aware of all of their options, discussing the benefits and risk of those options, and then jointly deciding is one of the keys to helping patients to adhere. I hate the word adhere, and I don't like the word compliant, but to help people choose a path that'll help them to get to where their desired outcomes are. And once again, we have some wonderful experts at Johns Hopkins that are working on the area of shared decision making. So that's a bit about health literacy. So I want to talk to you a little bit about some stuff that's under development. And I'll start with a little bit of this one. Remember I talked about the visual learner and the ability to see? We've been working with 3D animators with the idea of how do you create understandings of what a surgical procedure is. Because so often we have patients that come that don't fully understand what the procedure entails and what the recovery looks like. How does a medicine work? What's happening when that allergen appears in your body? And why is it that that then results in a runny nose? And then how does that medicine work to deal with that particular situation? The visual of that can be extremely powerful. And so we're in the process of doing some work in this arena to make that more commonly available. So I'm extremely excited about that work. Streaming patient education. I was talking to, when I look at barriers to patient education, and I think about patients being overwhelmed. So I think about those two things together, come together here. One of the things that I think about is the fact that when someone is going through a serious health condition, it involves them and their loved ones. And one of the things I would share with you is in any critical conversation, it's extremely important, if possible, for that our patient to have a support person with them. It increases the transfer of knowledge significantly. And so when you think about that, and we found in one particular case, what was happening was there was a surgery that we were doing, and there was an hour-and-a-half class before that patients should take before the surgery. And we were finding only 48% of our patients and their loved ones could attend. And so how do you solve that? Realizing that some of those patients have work that they can't get off, they're using the time for recovery, loved ones have been stretched, all those types of things. And so in the next month or so, we are going to do, much like colleges do, we're going to stream patient education. So that person can attend in person, or they can go into their patient portal, they can access the visit, and they can join the class from their home, their office, or wherever and be a part of that, and they can join the Q&A sessions. And so I'm really excited that that's happening, and so we can do those pieces. We're expanding that in the next month and a half to 2 months. This summer, I spent some time thinking about, I'm a Midwesterner, as Sharon has shared, and I was also in North Carolina in the Triad area. The Triad is not as humid as the coastline is. So I'm moving to Maryland and enjoying our summers here where it's just very humid and oppressive at times. I thought of our heart failure patients and our COPD patients. And I realized that a large number of those patients are stuck in their homes because of the weather. And they can't get to the support groups that help them through these times. And so what we're going to do is we're going to take their support groups and we're going to continue them in person, but if you can't attend in person, the ability to stream in FaceTime, Skype type technology to be able to bring them into their support groups so that they have the ability to socialize and share, and the concerns of loneliness and isolation disappear. And so we're going to begin to do those things too. We are heading down the road of podcast. I believe podcasts are a very powerful tool. And so we're going to be doing prescribed, dedicated podcasts, not like what you see out there today. These will be ones that are for, because what you see in podcasts today are a lot of times, if you're wanting more information, that type of thing. What we're looking at more is you have been diagnosed with. And so all the things you see in the written form and the visual form will now be available in a podcast format and formulated as a podcast with that style in mind. The very first of those will be coming out this spring. This is something I have not actively done yet, but I want to do. is I believe gaming is a very powerful part of the future. Gaming has taken over large parts of the work that we do, and I believe that patients can have fun and they can learn at the same time. And so we're going to go down that road at some point. A very short story, because I know my time is near. 5 minutes. So I'm going to share a story about a lady who very much touched my heart, and unfortunately that showed up together. They weren't supposed to. So you'll lose the surprise a little bit. So what happened is one day on a Friday afternoon in November, I was doing some research on heart failure patients, and I was interviewing them as they were discharging. And I met this lady, her picture's up there. That's not her, that's just a Google lady or something like that. But anyways, this picture I had sitting around. But anyways, what happened is when I talked with her, she was able to tell me, I said, what is your main problem? And she said, well, I had heart failure, which means our heart doesn't pump enough blood to supply my body. And I said, so what do you need to do when you go home? And she checked off every medicine she had to take and her visits, and she told me why she was taking the medicine and why she had to do the visits. And I was just ecstatic because all this work we've been doing, and I'm seeing the results, and she was like the exemplar. And then she lowered her head. And she said, you know, my kids don't want me to drive. And she was 80-some years old. And I said, that's too bad. And she said, I don't drive into traffic anymore. I don't drive at night, and I don't drive in rush hour. And I'm real careful. And she said, besides, I just got my car painted. And I said, really? I said, what color did you get your car painted? And she says, black cherry red. And I was like, oh, that's my favorite color. And she said, then I also just got my interior done. I said, really? And I said, she goes, yep, black leather. At that moment, I'm sitting there going, I need to know what she's driving. And as you can see on the bottom corner here, she said, I'm driving a classic Mustang convertible. And at that moment, she placed a vision in me that has maintained and drove my work ever since. This work, while I talk about all the things of readmission rates and satisfaction and improved outcomes, all those kind of things are very important. But what do those things really mean? It means that that lady is now in her car in a North Carolina summer with her top down, driving down the road with the wind flowing through her hair as opposed to being in the hospital. And that's what health literacy is about, is giving patients the information they need in the way they can use and understand and act upon so they can live their life the way they want to. Thank you for the opportunity. Any questions? All right. Doesn't sound like there are.
So I wanted,
Oh, got one here.
Hi, thank you so much for the presentation. So you brought up the point about how people learn differently, and I was wondering, is there a way then to measure health literacy on like a practice scale or on a larger scale, and how effectively we're communicating this information if people are learning differently? What do we measure to see if we're being effective?
That's a very complicated question, actually. It's going to take a little while to answer that. There are several schools of thought here. There are several different tools that measure a patient's health literacy, so there's that piece. And they have different levels of use. Some people believe that it's an important diagnostic tool as we interact with patients to understand where they come from. Others believe it's a universal precaution. We treat all patients as if they have a need for understanding. There are some tools that can measure just simple questions to help you understand how a patient prefers to learn, just simply asking, how do you prefer to learn? And I think that's going to become a much more standard question in the future as we have more tools. And then to measure the transfer, the effectiveness of your communication, the best tool, I believe, at this moment is just really simply to teach back a return demonstration. We do all kinds of testing, and we can do that. But from a practical point of view, because a lot of stuff I look at is just more, as opposed to the research side of it, more the practical side of it, is that now in the research side, there's a whole lot more opportunity. Did that help or no?
bit, yeah. Thank you very much. Just to follow up on that a little bit, I was just wondering if you could do it on like a higher level, like beyond the individual level, to see if, say, you were with the medical practice, how is your practice doing?
Oh, absolutely, absolutely. Yeah, you see that in, there's the satisfaction survey pieces that are done, and one of the tools that are done there is there's a couple questions about understanding your medications and your communication with your providers and your teams. Those are done, and the work that I've talked about has moved. The most dramatic I've seen, I took an emergency department from the 0th percentile to the 90th percentile in satisfaction. And I took a series of urgent cares from 60 to 80% is where they wound up in the high 80s. And on average, about 10 to 20% increments up. So you definitely can make those changes for sure. Go ahead, please.
Thank you so much for the presentation. First thing is a comment. I don't know if you're familiar with the work that Hope Lab has done in terms of gaming, and I think they're out of Stanford, but I would encourage, young adults in cancer and young adults understanding their own cancer. The question I have is, can you point me or us to institutions where they're able to assess learning preferences and learning differences prior to the appointment? So in the interest of time, practitioners are kind of more prepared. I had a dramatic example of this yesterday where I had a patient, I think her actual literacy was really low,
Right.
but didn't even realize after multiple appointments what type of cancer she had. And I tried to assess her learning style in a way that was very respectful, because I actually think that she might have had some real just basic literacy problems. But institutions where, or best practices of how you assess before the patient arrives.
So there is, so do you work here?
Yes.
Okay, ambulatory?
Yes.
Okay.
Yes.
All right. Yeah, inside of the ambulatory EMR build, in the education activity, is something called the Learning Needs Assessment,
Okay.
and that would help you down that road.
And that could be potentially administered before a first appointment?
It can be done before, it's designed to be done before the teaching occurs.
Okay.
And so that's when it's designed for. So it's a verbal question and answer kind of thing.
Okay.
Beforehand, I'm not sure if anybody's doing it, but if you send me a note, I will put a post out and find it for you.
Okay. Thank you.
And Tom, if you could please provide your email address.
Sure. My email address is tbauer, the number 9, at jhmi.edu. So once again, is tbauer, the number 9, at jhmi.edu.
So if I could just add to your comment, Tom, I think it would be really helpful, because this is what I think you're saying, is, excuse me, when you go into my chart and you do your pre-visit, sign in, if there was something there that would ask those questions about learning style, that might be.
Unfortunately, I think that's definitely a good idea. A small subset of patients, of course, don't, and the patient
Right.
don't even have access to my chart
Right.
because they don't have an email account. But no, I think that is a great idea.
It could be something we could add to the demographic section
Yes.
of
Yeah.
EPIC. We're getting more aggressive there. But I agree. And then the other thing just to keep in mind is that there are preferred ways, but most of us are multimodal learners. And so we look at it from different perspectives. So for me, certain things I want to see, certain things I want to hear, and certain things I want to touch. So it depends also on what the message is.
And isn't it required now that there is a learning needs assessment done on each clinic visit?
There is,
thought that was a joint
within
commission
Johns
requirement.
Hopkins, there's a
I think it's in
policy
the-
that says for
Yeah.
every admissions, you must create a learning needs
I
assessment.
think it's outpatient.
And once a year in ambulatory, there's a learning needs assessment that's done.
Okay.
Yep.
And what section, do you know what section that's in? Is that in the,
What's that?
do you know what section of the record that's in?
It's in the education activity of EPIC, and there's a little tab on the toolbar on the top that you go to.
Okay. All right. Well, we want to thank you again, Tom. This has just been excellent. And to remind you, Nicole has tickets. There's pizza for the people in attendance. So if you'll get your ticket from Nicole, please join us for pizza.
Great.
And thank you very much.